help help to reduction of investment in health workforce in our country. So the benefit of three, we call benefit to those partnership for people. They can get job, they can be high, they can get income, and they feel happy, particularly for disabled, and so they get their well-being and social support. For public hospital, they have an effective and sufficient man, money, and material resources, and also equity and quality of health services, and also they get a social engagement or community engagement. For private sector, they get social accountability, and those are win-win situation, triple win situation. And we have the next plan for ongoing research on this kind of movement on different contexts, and we will analyze as to get the evidence to propose the policy maker for recommendation or for movement on this issue. Thank you so much.
Thank you very much for the speech on people public. Okay. Thank you very much for the speech on the people-public-private partnership in the healthcare system management and primary healthcare. So next, I would like to introduce you Assistant Professor Dr. Phudit Tejativaddhana, Director of Asst Institute for Health Development, collaboration with neighboring countries in the developing health workforce. Assistant Professor Dr. Phudit Tejativaddhana is a general practitioner and has been in senior executive role both in the public and private sector. He is a founding director of the Lower Northern Region Heart Center at the Naresuan University, advisor to the Minister of Public Health, member of Standing Committee on the Public Health, member of Subcommittee on Health Service Reform, National Reform Council. He will be sharing the experience from the Faculty of Public Health at Naresuan University and initiate the Graduated Return Home Project and the outcome of their retention. So please welcome.
Thank you. Good morning all. First of all, I'd like to thank Professor Win to invite me to share my real experience when I was the Dean of Faculty of Public Health at Naresuan University, the public university up north. It's quite confusing. Now I moved to Moderator University, but I have to talk about my past experience. I implemented one project, and we used the term like the integration approach for public health professional education in rural Thailand. This is my work experience. And as you can see, Phitsanulok is the province in Lower Northern Region, halfway from Bangkok to Chiang Mai. I hope you know Chiang Mai. Faculty of Public Health Naresuan University in that time was the first Faculty of Public Health in Northern Region, and we did one project called Graduate Return Home Scholarships under the patronage of Her Royal Highness Princess Rinthorn. And I do hope that my presentation will reinforce what Professor Wanicha just presented to you. Let me introduce about public health officer in Thailand. Probably many of you may know, but some of you may not know. When we call public health officer, their role is to provide primary health services, mainly about health promotion and disease prevention, and also facilitate community participation. However, due to the shortage of medical doctors and nurses in rural area, so most of them have to provide basic curative care and rehabilitation, and under the supervision of doctor or nurse, but actually they play that role by themselves. And some of them may work at the district health offices or community health department of the community hospital as the public health academics or public health manager. So we can say that being the public health officer is the important person in the primary healthcare sector, actually, mainly at the sub-district and district level, to be a team of the medical doctor, to assist medical doctor to work better. our challenges in that time when I was a dean, we asked them ourselves, how could we train enough public health officers, but not just in terms of number, but with the appropriate skills to meet the needs of the population, to meet the needs of the challenges in the 21st century. And secondly, the more important is that how can we motivate the young generation to want to become the public health officer and be retained in the system. What we try to do, we use the system approach. Actually, the inspiration comes from paper published by Professor T. Norris in 1995. In that time, I worked for the Faculty of Medicine, and I had the opportunity to get involved in doing the medical education, and we call it new track medical education. Because of limitation of time, I don't want to go into the detail, but just want to set the scene that we got the idea from rural medical education and retain rural medical doctor and implement in the Faculty of Public Health, where I got the chance to become the manager of the faculty. So we mapping the pipeline of the system, how to retain them. We focus on three main stages: recruitment and selection, training, and retention. And for this presentation, I will focus just only on two stages: recruitment and selection and training. As you can see, most of the rural students, they want to become the doctor, they want to become the public health officer, but their challenges are that they don't have money, first. Secondly, they don't have enough money to go to the school. And thirdly, motivation, the lack of motivation. Even they want to think about getting to the medical school, getting to the public health school, they dare not to think about, because they think they are those people who, many people left them behind. But we try to use this project to tell them that no, if we come together, we will achieve this goal, we will overcome these challenges. At the recruitment and selection, the faculty, we seek funding by going to talk with the public organization where they have funding, and also private sector, to provide fund for supporting high school students in rural areas. And secondly, the students were recruited not after they graduate from high school, but before they graduated, we go to find them when they were the last year. And we engage the representative from local health services and local community in the selection process. We ask the hospital director if they want to accept this student after their graduation, they will come to the program. And we think that doing this way, people and local health system are the co-producer of their own health workforce. For the scholarship, the tuition fee is just only $4,000 for 4 years. And we also use this scholarship to provide living allowance for about $4,000. And also we give them financial support. Every academic year, they have to go back to home. Actually, they have to go back anyway, but we support them for the logistics and ask them to perform volunteer work so that when they go back to their home, they not just only meet their family, but they do something, contribute to their community. And every semester, they have to report the result of their study. And at the training stage, we ask the Ministry of Public Health to provide our support by providing the public health training site. We ask for 2 districts in province up north to become our public health training site. And also we ask the local health professionals in that area to become our adjuncts, and we provide capacity building. Students will spend at least 1 semester with those local health professionals for their practical training. And also, we add up with the project I call One Path project, one project, one area, one teacher. That means the academic in my faculty will get funding to work with the local health officer to do research according to their need. And also the student go with the lecturer to stay in the local health services and do research with their lecturer. This is the result. We run this for 4 batches. The first batch, we got 18 scholarship. Second batch, 10 scholarship. And third batch, 15 scholarship. And fourth batch, 10 scholarship. They come from 15 provinces in North and Northern region. And this is the result for first batch. They can retain in the system now 72%. 5 left. Unfortunately, one got death after she graduated from motorcycle accident. Very sad. You can see the second batch. We have 10 scholarship, 7 still working, 3 persons resigned. Unfortunately, one resigned because they have no available position, even though at hospital commit to provide position for her. Unfortunately, the complete hospital director moved to the new hospital. So the new one cannot keep the promise. The third batch, as you can see, we can provide for 15%, 13 still in the rural area. And this is just the last batch. They just graduated last year. Everybody still go to work except one student not graduated yet. Just want to show you one of them work very well in the rural area and is kind of like role model of the other. So this guy is a huge Thai people. If they have no any scholarship for him or no this project for him, he said he never think about come to the school. So in conclusion, even though this project we think is good, but I think it's not good enough to retain them. We need multi-strategy, not just only education, but also strategy in the health system to go together to retain them. Sorry, I used too long time, but I would like to say one thing. Secondly, I think we need more research to assess if the competency of these people meet the need of the people or not. What happened? What is the impact of this project to those who provide funding, to those in the health system, and also to them and their family? Thank you very much. And apology for taking longer time than I.
Thank you very much, Assistant Professor Dr. Phudit, for your sharing of experience and also the presentation. So next, I would like to give you the experience of from the perspective of student. What I mean is the medical student. So please welcome Ms. Pornapat Manum, the member of International Federation of Students Association Thailand, FMSA Thailand, and student at Faculty of Medicine, Chuenkongkaew University. Ms. Pornapat is a second-year medical student at Chuenkongkaew University and has been working nationally on advocacy of Thai medical students along with the official committee from IFMSA Thailand. She will be talking about the Gen X and Generation Y and Gen Z and the future health workforce curriculum and extracurricular activity that encourage the community health awareness and practice among the medical students. Please, forward with you.
Good morning, honorable guests and fellow speakers. And today I'm mainly talking about Gen Z because I am a member of the Gen Z. So here it is. So thank you, baby boomers, Generation X and Generation Y, for shaping our world into what we are today. And yeah, we're Generation Z. And we are the new future. Yeah, and thanks for passing on the baton for us to be one of the economically active. And as a member of the future health workforce, I would like to share some the notable characteristics of our generation. So this is us. And this? Well, because we grew up with technology, we're prone to short attention span, or in other words, boredom, and instant gratification and multitasking. On the other hand, technology brings forth the growth of globalization and opportunities for entrepreneurship. So, how are the adults preparing things for us? Well, we have inter-career act probably every Thai medical school, and yeah, it's compulsory for us to take this course. The objective of this is here, and students are given the opportunity to rural areas and big projects that will help solve issues within the community. In my university, Chuenkongkaew University, we have other activities. Last December, we second-year medical students participated in an activity called patient shadowing. And it's an activity where students are assigned to follow a patient for the whole day and see what they do. The objective is for students to be able to empathize with patients. And apart from the positive feedback from our students, this Facebook post illustrates a glimpse from the patients. And at our university, we also have self-development workshops, so students can understand themselves better and understand others, so they can provide a humanistic approach to treatment. We also have three electives that will center around community-based approach. So moving on to extracurricular activities, we have healthcare camps, and in these camps, we do those organized by universities, such as Naresuan University and Camp and Moderator Camp, are collaborations of healthcare faculties, including medicine, veterinary, pharmacy, nursing, allied health sciences, and dentistry. Yeah, we can use our own skills and that we acquired in our faculty to treat patients. And for those camps exclusively for medical students, and the examples are as in the PowerPoint. And this is the evaluation from Shira's Health Volunteer Camp, which is conducted by fourth-year medical students. And as you can see, there are increases in willingness to study medicine or eagerness to join the class. Yeah, so it really helps inspire us to become better doctors. And there are also community service camps, which doesn't center around healthcare, and they exist in most universities and are open to every faculty. And their activities range from planting trees to constructing buildings to teaching children. So, helping us to empathize with patients. But I believe that, we believe that with just empathy alone from our education wouldn't be able to stop us from returning to the cities. And I think that there are 4 factors we have to consider if we want to retain doctors in the rural areas. Firstly, community-based learning. Community-based learning familiarizes us to the rural areas. So once we graduate, we can be more accustomed to working in such areas, and hence making it more comfortable for us. We need education that will encourage self-development so we can provide a holistic care to patients. Decentralization and empowerment. To me, I think this is the most important point, and it's the standard of living. Well, most medical students now are from the middle to upper class in the socio-economic system. And yeah, we live with 4Gs and smartphones and like 7-Elevens at every corner of the road, and then you expect us to go to rural areas and with like not 24 hours of running water and electricity, like can you imagine that? Yeah. So I think there has to be a decentralization of the development in these areas. And it becomes a more significant point when we become parents, because parents want the best for their child, and good education would be in the center, wouldn't it? And also, there needs to be decentralization of the system itself and empowerment of district hospitals. Currently, district hospitals, they only have minimal procedures, and we have to refer them to regional hospitals, which causes cramped and crowded places in the regional hospitals. And if we can minimize the cost of healthcare equipment, it would mean that we can buy them and put them in the district hospitals. So that would increase the number of procedures we can do in those hospitals. And the health workforce in these hospitals need to have their own power to make changes. They need to realize that they are a pivotal part of the UHC and the SDGs. So workload. We are expected to treat patients, refer cases to regional hospitals, manage the hospitals and evaluations to the ministry, and keep up to date with advancement in healthcare. Yeah, all that, and that's an addition of a decreasing number of health workforce in every area. And that moves to my next point, opportunities and influences. We're Generation X, we're Generation Z, and yeah, we're young entrepreneurs, and we view that money is the world's fuel. And our work comprises of that sweat and tears, but our salaries constantly get delayed. So being a specialist would bring about more higher pay and progress in career. And the city has more opportunities for us to accomplish further in our careers. In a field where our peers are rewarded for groundbreaking research, treating patients in the middle of nowhere just doesn't achieve justice. And we're the East Keyboard Generation Z, referring cases is mundane routine work, and we would not be happy with that. Lastly, good governance. Working at the grassroots level, we expect our leaders to appreciate our existence. We need assurance that our leaders are endeavoring to shape our healthcare system and our country into something people would call hope. We need to be heard. We need inclusiveness, and we need policies that aren't just baseless promises, but real implementations. We need transparency in managing hospitals, and we need to stop people from taking advantage of us. We need them now. Finally, Finally, I would like to end my speech with a quote engraved on my class building and hopefully engraved in all Thai medical students' heart. The consideration of personal gain takes second place for the overall benefit of mankind. Prestige and wealth are natural rewards for just and sincere dedication to work. It's a quote from His Royal Highness Prince Mahidol Buddinade. Thank you for your kind attention.
Thank you again for the perspective and also the direct experience as a medical student. So we already heard the perspective of a Thai medical student. Next, I would like to present you the perspective of medical student too, but right now it's the international perspective. So please welcome Ms. Cynthia Lam, the member of AMSA Hong Kong and student at Faculty of Medicine, University of Hong Kong. Cynthia is a contract consultant at Global Coordination Mechanism NCD for Health Organization and a former president of Asian Medical Students Association Hong Kong. Her interests include digital health, health literacy, and young empowerment. Currently pursuing her medical degree at Hong Kong University, Cynthia is also an advocate for young empowerment. She is an active member of the International Federation of Medical Student Association, and she will be talking about the capacity development for young generation of health workforce in a digital competency, research skill, and soft skill for the future practice, engaging young in a remote healthcare strategy. So please take your time.
Thank you so much for having me here, and I know the room is getting chilly and we are desperate for a cup of coffee, so I'll make this short. Thank you so much for the kind invitation, Professor Wanicha, as FMSA Thailand. It's a great honor for Fa and I to speak about the youth perspective, as we're very early on in our health career. We get to be on this panel with this very renowned speakers and experts in the field. So I will basically address two questions. Number one is, so we're talking about investing in health workforce, but how exactly are the young professionals investing in ourselves? And the second question I would like to address is, what is one of the good ways to invest in us, from my perspective, as a young health professional, as well as someone who is very passionate about digital health. So to answer the first question, it's kind of like a boom answer, one sentence. Peer-to-peer capacity building is essentially what we are doing worldwide. When we talk about community-based approaches, we often forget that the network of young healthcare professionals is a community itself, and we are doing a lot in terms of investing in ourselves. And opportunities like PMAC are wonderful for young people like us to learn from experts in the field, because you are really the role models for us. But we are the lucky ones. Not many people get to go to conferences like this, so we realize there's a need for us to have our own trainers in different areas, in terms of soft skills, in terms of knowledge that are not taught in a formal curriculum, such as human rights, medical ethics, a lot of public health issues that our curriculum just cannot address. So what we do is something called peer education. We train our own trainers who train a new generation of trainers in different areas. And my peer capacity building journey starts with the organization called the International Federation of Medical Students Associations, FMSA, which is one of the oldest student bodies in the world, and we invest a lot in capacity building. And just speaking from my own experience, my journey started about 5 years ago at my first FMSA meeting in Mexico, where I learned about capacity building in creative communications. And we basically had this wacky idea of think of something that's really crazy and wild, and think of something that's super boring, like producing pamphlets about diabetes. And then you combine these two crazy ideas together to come up with the perfect creative communications campaign. And we work with very limited resources, just a big sheet of paper, some markers in an empty room. That's how we work. But from a trainee back then, I became a trainer, and I taught about creative communications as well as human rights in professional setting. And it's just how a lot of medical students, healthcare students grow in a journey, and the capacity building from a trainee to become a trainer is also a wonderful training itself, because it trains your leadership skills, communication skills. And it's something that we cannot teach us, we cannot learn at school, which is really precious for our network of healthcare students and youth. And very encouraging thing, which is it's not just one organization doing it. There's numerous organizations doing wonderful work in capacity building. And FMSA, UNMGCY, AMSA International, and so on and on. There are so many that are not on the slide here. And just there are more than 120 countries being involved, as well as 2 million health students involved in one or more networks. And some of these networks are actually not just for health students, such as UNMGCY, which is even better because we get the opportunity to work with people from other professions. And we also address different SDGs together. And it really is highlighting the importance of interdisciplinary work outside of the context of healthcare. And one thing that we highlight is that we're not just about sharing knowledge, it's also about transforming knowledge into practice. So in my capacity locally at AMSA Hong Kong, we do a lot of different interventions locally as well as internationally. So from capacity building, we're able to do a lot of different interventions in our community, such as disabilities, inclusion, mental health, asylum seekers, advocacy, rare diseases. And of course, we also do more capacity building for our fellow students. And it's something that we really value, which is transferring knowledge into practice. The second thing that I'd like to address really is what is one of the good ways to invest in us. Earlier in December, I was invited to speak at the WHO Global Meeting on NCDs in Oman, and I was asked a very specific question, probably due to my interesting background of both pursuing a medical degree while working on digital health and communications. And I was asked, how can we best prepare and motivate the healthcare workforce in the use of digital solutions to combat NCDs? That was an NCD meeting, but now we're not just talking about NCDs, and in fact, digital health is everywhere. Yesterday I went to a very good side meeting organized by Access Health, and they really highlight that digital health is one of the essential pillars to universal health coverage. And whether or not you agree with it is inevitable that digital health is happening now, and we have to deal with it. So Deloitte recently published a wonderful report, 2020 Global Healthcare Outlook. And it says that a technology-enabled evolving care model has the potential to change physicians' future roles in healthcare delivery, infrastructure, and enablement. Transition is already underway, and we expect it to accelerate over the next 5 to 10 years. And I think we all know that it is happening, but we keep forgetting how fast it is that it is happening. And currently, our healthcare professionals are not really prepared for the digital health future that we're looking at. My school doesn't have the curriculum on digital health training. There is no any formal sort of curriculum about how to work with people from other disciplines of work, such as engineers, innovators, programmers, designers. And my ask really is we need to start thinking about training formally in our curriculum, because when we talk about we need to prepare for a digital future, there's no way that we can rely on healthcare workforce not being digital savvy and being able to use all these new technologies. And I'm not saying that we need to train all our doctors to be jacks of all trades, that they need to know how to program, they need to know how to design while needing to cure patients. But there is a need for us to know how to communicate the needs identified in the healthcare system and be confident and comfortable about communicating those things to other people and be comfortable with using new technologies because they are underway in the next 5 or 10 years. So we're just going to end my presentation with this slide here. It's a bunch of codes. I'm not asking who knows how to code here. I don't know how to code myself. But the future we're living in, program is going to be one of the main languages used. And I'm not even going to ask who knows how to code, but like who in the room will feel confident or comfortable understanding some codes in a context when you communicate with programmer, or you understand what code, what language is used here. Because when we are preparing for a digital future, we really need to make sure that the healthcare professionals, public health professionals know very basic things about programming. And we need to start investing in the healthcare professionals now in order to be prepared for the digital future tomorrow. So thank you so much, and I look forward to more discussions later.
Thank you, Ms. Cynthia, for sharing her point of view from medical student in the international medical school. So it's a time for our session of Q&A again. So let's start with any question from the floor. Please. We will have time until 10:45, so please enjoy the session.
Good morning, thank you for the presentations. I'm Kevin Miles from Health Education England, and I think particularly the last two presentations were absolutely critical to the session and thinking about the future. And I know, talking from our experience in the United Kingdom, Health Education England has looked at the workforce needs up till 2041 and looked at an ageing population. Similarly, we've got healthcare workers who are moving towards the centre of England. And in 2041, if you're ageing in the southwest of England in Cornwall or in the northeast of England up in Yorkshire, the workforce at the moment doesn't look like it will be there, and yet we've got a growing need and growing burden. And thinking about what we do now, I'm told in 3 years' time, artificial intelligence will be better at reading histopathological slides than a human eye, and it'll be negligent if we don't take on some of those technologies to diagnose cancers and look at cervical smears and such. So why are we still training pathologists in the same way as we have for the last 20 years? We need to think about the future. And a range of diagnostic radiologists won't be looking at x-rays in the future. Computers will do it for us. Computers will be better at identifying lesions in a whole range of radiological imaging. So again, we need to think about not just doctors and nurses, but the whole range of allied health professionals and what technology they'll be using in 20 years' time. We know that it takes 10, 15 years to develop a medical consultant. So what will the technology look like in 10 to 15 years when they are a consultant? They won't be practicing as they learn now. So there's huge challenges. So I think those few things that you've brought in at the end are absolutely vital. Thank you.
Thank you for your question and your comment. Please, the next question.
Hi, Ryan Lee, also from Health Education England. I just want to take this opportunity also to thank Professor Wanicha as a co-host for this SAG meeting for the Better Health Programme funded by the UK Prosperity Fund. I think the thing that strikes me is that a lot of these global health meetings, we don't often involve where this is about investing in the workforce. So I'm really glad there's been the effort to involve the workforce that we're trying to invest in. That's really wonderful to see. I've got two questions, one for Professor Wanicha. The PPPP model, very interesting. I'm interested to know if you have any insights on how do you ensure the private sector are engaging positively in the model, and for example, what safeguards are there in place to prevent or mitigate against conflicts of interest? And my second question is for Cynthia about digital health. So you mentioned digital health is the future for the workforce, but then earlier you also mentioned that Generation Z, you're used to your 4G, 5G, and not willing to travel in rural areas. Isn't there a conflict if digital health is the future, but rural areas, they're not getting the investment that's needed at the moment to bring them up to speed with digital health? From your perspective, what do you think is needed in terms of workforce investment to ensure that these rural areas are also empowered to take advantage of the of this changing dynamic in the healthcare development? Thank you.
Thank you for your very good question, but very difficult to answer. For conflict of interest for private sector, because it's already regulated in the bill. So this the regulation for private company to implement, to run this program for the disability. So those disability will get their confidence, the confidence for their life. Previously they feel some in confidence in their life, even for their social, for their education. So after this get support from private sector, they feel more confident, and this make a good relationship between private sector and those with those disabilities, and also the partnership with the district or community hospital or even local government. So this kind of some they may make feel some happiness and some good relationship. Yeah.
Thank you for your question. That's exactly one of the biggest challenges we're facing right now when we're talking about digital health, and there are so many low and middle income countries lagging behind. And currently, together with Dr. Guy Ferns and Professor Richard Osborne from Australia, I'm actually conducting a global situational analysis on how different member states are using technologies to combat, to address health literacy on NCDs. And one of the key issues we identify is that they lack infrastructure. And one of the member states we interviewed actually, they say that 10 health facilities, 9 out of 10 actually don't have basic 3G. And that's shocking considering we live in the digital age. So one of the key asks from that global situational analysis we're conducting is that we need to first invest in infrastructure, making sure we catch low and middle income countries up on this ride of digital transformation, and make sure we invest in basic infrastructure of internet first. But I guess at the same time, it's really encouraging to see countries such as India that people have more cell phones than anything, and we really are riding this age, this wave of transformation. But like you said, we have to first address the importance of basic infrastructure in those countries.
Next question, please.
Göran Thomson from Karolinska Institutet and SITE, Swedish Institute Global Health Transformation. Thank you for the presentations. I particularly liked some of the interventions dealing with how to combine craziness with boring leaflets. I think that in a way describes the frame. I'm concerned that we are not more innovative. I think there is a problem, I don't know, there seems to be a problem also with this microphone. Maybe someone wants to disrupt, and I think my voice is clear enough. Is that okay? Apologies. Now, there are 3 levels of knowledge in healthcare, globally, in Sweden as well as in Thailand, as well as in African countries where I've been working. You have the financial capital, and that differs very much. Huh? You have the knowledge capital, and I think there are few industries with so much knowledge as the health industry. And then you have the moral capital. Now in Sweden, the moral capital is eroding. It's not as fancy to become a nurse or a doctor, etc., as it used to be. And the retainment, not only in rural areas, but all over, is changing to a very, very high cost of an already costly system. And I'm sure this is an increasing global phenomenon. So one needs to find the incentives that makes it attractive, not only from a Buddhistic point of view, but in general, to become a health worker. And here, of course, technologies as presented by the last 2 interventions is important. There are 3 levels of learning, and these are more comments, but I would like to have comments on my reflections, if possible. You have the informative learning that creates experts. This is very easy, very conventional, not so attractive. Don't need much of universities. Information is and data is available in so many ways nowadays. Okay. So then you need to add values, and that was referred to by one of the presenters, but I think too little. This means ethics and other aspects, increasing the opportunities to preserve the moral capital of the health workforce. But that's not enough. Actually, the health systems everywhere, in Sweden included, changes much quicker than the educational systems. I'm very concerned, for example, with Karolinska Institutet, well known for the Nobel Prize, that we are conservative, not moving enough. The system is developing much faster than the education. So you need to add some dimensions in the training that makes it possible for those that come out after the learning to become change agents. So you need leadership attributes. I'd like to know a little bit about how these 3-4 reflections of mine are being translated in what Dr. Wanicha and others in the panel are doing.
Just a more sort of a general comment on sort of learning, the nature of learning. So there is a group called The Net, which is connecting medical schools that have different approaches to learning, and basically encouraging the development of learning in the context in which people want to work. So that's one approach to ensuring that people, as they learn, are engaged directly with their community. And it resonates very well with the approach being taken in Thailand, but again, building up the evidence base is important. The other important point I wanted to make on digital, though, is that there's lots of information available digitally, but not much quality assurance of that information. And that is a real challenge, because we don't necessarily have critical consumption of the knowledge that is available, and lots of people are using misinformation. And my concern with this over-reliance on digital, unless we create critical consumers of digital information, then we're creating more problems than finding solutions. And it takes us back to this whole idea of health literacy. So if we go back to Paulo Freire and the pedagogy of the oppressed and the need for health literacy, which was then just seen as a lack of information, we've now got people with lots of information but no idea what is the correct information. So I would say one of the key functions of medical schools and medical education is, as you say, to equip people with the values, the ethics, the critical appraisal skills, and the communication skills in order to engage with and support communities to gain not only health literacy, but also digital literacy for critically using the information that is available. And unless we collectively empower now communities to use information effectively, then we're going to fail, as we have done in the past, to enable people to have health literacy. So I think it is a real challenge that you're posing. A very interesting one that I think collectively we need to share experience on how to address.
From my point of view, how to teach our students to have their soft skill, we call it soft skill. It's mean the creative and communication skill and whatever ethic. Right now, for disruptive on technology, we use this technology as a tool, as an instrument to support their knowledge. But we try to teach them to learn as a workplace based. So right now, we have a new program for medical students, and right now, and for nursing students as well. We have a learning center at the community, and those community is a good learning center because we have a role model from the director of the community hospital or district hospital, and those will be their role model, and they will get their perspective from those persons. I think this will help our students to learn effectively.
Can I just add something from the project that I and my colleague did up north? We decided that every semester break, we ask our students in the program, when they went back to their hometown, we asked them to do volunteer work with the local health services, where in the future, these local health services will be their workplace, so that we can tie up relationships between local health services and also themselves. But behind that, we would like them to have a sense of gratitude because they come to study, because somebody support them. So they need to contribute, not just, we don't aim to them to contribute financial, because we know that they come from rural poor family, but what they can contribute is to show the society that they can do something for their hometown. Thank you.
May I ask a question for HEE and NHS? For both of your organizations from UK, right now for HEE, you remove to very special things, genomics or digital or e-learning. But for national health services systems, to move for primary health care, for family physician, for general practice, how can you cooperate or coordinate those kind of things to move on the same direction?
Well, I think somebody mentioned the importance of continuing professional development earlier on. I mean, the problem is the bulk of our health workforce were trained 10, 20, 30 years ago, and therefore keeping up to date, I mean, with Generation Z who access that information and maintaining their skills is challenged.